Good morning, good afternoon, good evening, wherever you may be watching us in today's video. We will continue with Dr. Frank Netter's flashcards on human anatomy, starting this time with the spine, the vertebrae, the cervical vertebrae, the atlas, and the axis. You can follow my pointer along for the labeled parts. Number 1 here, anteriorly, in the atlas vertebra, also known as C1, is the anterior tubercle. Laterally, on the lateral ends of C1, again known as the atlas, is the transverse process. Medially is the superior articular surface of the lateral mass for the occipital condyle. And posteriorly and medially is the groove for the vertebral artery. Going down now, number 5 is the transverse foramen, and posteromedially is the anterior arch of C1. Going down from the atlas or C1 to the axis or the C2 vertebral body is number 7 here, the spinous process. The spinous process is the most posterior aspect of the axis or C2. Number 8, the dens. Number 9, the superior articular facet for the atlas. And number 10 is the pedicle. The first cervical vertebra is the atlas, and it is named after the Greek god Atlas, who is often depicted with the world on his shoulders. The atlas has no body and no spine, but is made of anterior and posterior arches. The transverse processes contain a foramen that transmits the vertebral vessels. Again, this is the transverse foramen. The second cervical vertebra is the axis. Its most characteristic feature is, of course, the dens, number 8 over here, also called the odontoid process. The dens articulates with the anterior arch of the atlas, providing a pivot about which the atlas and the head can rotate. Side-to-side action of the head, as in when indicating no. Clinical correlation: a blow to the top of the head may fracture the atlas, usually across the anterior and the posterior arches. Across the anterior and the posterior arches. Such a fracture of C1 is called a Jefferson fracture. Fractures of the axis or C2 often involve the dens, or involve a fracture across the neural arch between the superior and the inferior articular facets. This is called a hangman fracture. Therefore, Jefferson fracture is to a fracture of C1, whereas a hangman fracture is to C2, also known as the axis. We take a closer look at the external craniocervical ligaments. Number 1 here being the posterior atlanto-occipital membrane. Number 2 is the capsule of the atlanto-occipital joint. 3 is the transverse process of atlas or C1. Number 4, the capsule of the lateral atlanto-axial joint. 5, the ligamenta flava. Singular form of the ligamenta flava is the ligamentum flavum. Going down now, number 6, the capsule of the atlanto-occipital joint. Number 7, the posterior atlanto-occipital membrane. 8 here, the ligamenta flava again. Number 9, the ligamentum nuchae or the knuckle ligament. Number 10, more laterally, is the anterior longitudinal ligament, and coursing through each vertebral foramen is the vertebral artery. There's one vertebral artery on either side. The atlanto-occipital joint on each side is covered with an articular capsule and posteriorly reinforced by the posterior atlanto-occipital membrane. The ligamentum nuchae over here is a strong median fibrous septum. It is an extension of the thickened supraspinous ligaments that arise from the spinous process of C7 and extend to the external occipital protuberance. So again, the ligamentum nuchae eventually extends up to the external occipital protuberance. Our clinical correlation here is, while there are usually 7 cervical vertebrae, fusion of adjacent vertebrae can occur. Most commonly, this fusion in the cervical region is seen between C1 and C2, the atlas and axis, or between C5 and C6. So the fusion is either between C1 and C2 or C5 and C6. Moving internally to the internal craniocervical ligaments. Number 1 here, the capsule of the atlanto-occipital joint. Number 2, the capsule of the lateral atlanto-axial joint. Moving inferiorly still, the capsule of the zygapophyseal joint. The zygapophyseal joint being the joint between C2 and C3. Going down here, number 4 is the cruciate ligament. It's called the cruciate ligament because it is literally shaped like a cross. Number 5 here, laterally to the cruciate ligament are the alar ligaments. 6 is the posterior longitudinal ligament. And 7 is the tectorial membrane over here. The atlanto-occipital joint is a biaxial condyloid synovial joint between the atlas and the occipital condyles. It permits flexion and extension as when the head is nodded up and down, and some lateral bending. The atlanto-axial joints are uniaxial synovial joints. They consist of plain joints associated with the articular facets and a median pivot joint between the dens of the axis and the anterior arch of the atlas. The atlanto-axial joint permits the atlas and head to be rotated as a single unit, as when the head is turned from side to side. So again, the head is able to turn from side to side because of the atlanto-axial joint. These joints are all reinforced by ligaments, especially the cruciate and the alar ligaments over here. The alar ligaments actually limit rotation. Clinical correlation. Osteoarthritis is the most common form of arthritis and often involves erosion of the articular cartilage of weight-bearing joints, including the cervical spine. Extensive thinning of the intervertebral discs and of the cartilage covering the facet joints can lead to hyperextension of the cervical spine, narrowing of the intervertebral foramen, and the potential for impingement of the spinal nerves exiting the intervertebral foramen. Let us go down inferiorly into the larynx, starting with the cartilages of the larynx. Posteriorly here, the leaf-shaped structure is the epiglottis in number 1. Number 2 is the hyoid bone. Inferiorly, number 3 is the thyrohyoid membrane because it connects the hyoid bone to the structure over here, which is the thyroid cartilage. Number 5 is the thyroid cartilage lamina. Posteriorly, we have the arytenoid cartilages, and number 6, the vocal ligament. Inferiorly still is the median cricothyroid ligament, and you can guess why it is called the cricothyroid ligament, because it connects the thyroid cartilage over here to the cricoid cartilage. The cricoid cartilage is a complete cartilaginous ring. And inferiorly, we have the trachea. The cartilages of the larynx include the thyroid cartilage, the cricoid cartilage, the epiglottis, and the paired arytenoids over here. Not to mention the corniculate over here, and the cuneiform inferiorly cartilages. These paired elastic cartilages lie in the aryepiglottic folds and have no articulations with other cartilages or bones. The thyroid cartilage, over here, possesses the anteriorly placed laryngeal prominence, also known as the Adam's apple. This is the Adam's apple. The thyrohyoid membrane has an opening through which the internal branch of the superior laryngeal nerve enters the larynx to provide sensory innervation above the vocal folds. Clinical correlation: trauma to the cartilages of the larynx may result in fractures. Consequently, the underlying laryngeal mucosa and submucosa may hemorrhage, resulting in significant edema and the potential for airway obstruction. Ultimately, such an injury may result in hoarseness as the vocal folds swell and/or are compromised by the damage, such as muscle or nerve damage, making speaking difficult or even impossible. A special note, this time in the auditory ossicles. The auditory ossicles are comprised of the following. Number 1 here, the malleus, also known as the head. Number 2 is the handle of the malleus. The malleus is actually in contact with the incus over here in number 6. This is the lenticular process of the incus. And the incus in turn is in contact with the stapes. Number 3 over here. The foot plate, also known as the base of the stapes, is labeled as number 4. Our mnemonic here is MIS. Number 1, the malleus is in contact with I, which is the incus, and the incus is in contact with S, which is the stapes. MIS. The 3 auditory ossicles reside in the middle ear or the tympanic cavity. They amplify sonic vibrations from the tympanic membrane and transmit them to the inner ear. The 3 ear ossicles are the malleus, also known as the hammer, the incus, also known as the anvil, and stapes, also known as the stirrup. The handle of the malleus, in number 2 here, is fused with the medial aspect of the tympanic membrane. The head articulates with the incus. The incus articulates with the stapes, whose footplate is attached to the oval window in the middle ear. 2 small muscles attach to the auditory ossicles. The tensor tympani muscle, which attaches to the malleus. Tensor tympani attaches to the malleus. And the stapedius muscle, which, as the name implies, attaches to the stapes. These very small skeletal muscles dampen large vibrations resulting from excessively loud noises. So again, the 2 small muscles attached to the ossicles, the tensor tympani muscle and the stapedius. We are now moving into head and neck territory. We start with the muscles of facial expression, a lateral view of the muscles of facial expression. Shown here in number 1 is the frontal belly of the occipitofrontalis muscle. The occipitofrontalis muscle. The origin, This muscle has no origin. Its fibers arise and are continuous with two other anterior facial muscles, the procerus and the corrugator supercilii. The fibers are directed upward. They join the Galea aponeurotica, which is anterior to the coronal suture. The occipitofrontalis muscle elevates the eyebrows and wrinkles the forehead, as when a person looks surprised. The occipitofrontalis muscle is innervated by terminal branches of the facial nerve, again cranial nerve 7, and the temporal branch of the facial nerve. The epicranius muscle consists largely of the frontal and the occipital bellies and an intervening Galea aponeurotica. As a muscle of facial expression, this cutaneous muscle lies within the layers of the superficial fascia. These muscles vary from person to person and they often blend together. All of the muscles of facial expression are derived embryologically from the second pharyngeal or branchial arch and are innervated by the terminal branches of the facial nerve. Acute unilateral facial palsy is the most common cause of facial muscle weakness and is called Bell's palsy. In Bell's palsy, paralysis of the frontalis portion of the epicranius muscle would result in an inability to raise one's eyebrows and wrinkle the forehead skin. Again, this is the frontal belly of the occipitofrontalis muscle. Posteriorly is the occipital belly of the occipitofrontalis muscle. It arises from the lateral 2/3 of the superior nuchal line of the occipital bone over here and the mastoid process of the temporal bone. The occipital belly of the occipitofrontalis muscle inserts over here into the epicranial aponeurosis. The occipital and the frontal bellies of the epicranial muscle act together to draw back the scalp. This action raises the eyebrows and wrinkles the forehead. Same with the frontal belly of the occipitofrontalis muscle. The occipital belly is innervated by terminal branches of the facial nerve. The extensive aponeurosis over here in white is called the Galea aponeurotica. The Galea aponeurotica connects the frontal belly and the occipital belly of the epicranial muscle. This is the epicranial muscle, also known as the scalp muscle. Shown here again in lateral view, our crescentic, our circular muscle here, the orbicularis oculi muscle. The orbicularis oculi muscle. Origin: the orbicularis oculi arises from the nasal portion of the frontal bone, the frontal process of the maxilla, so you can follow my cursor over here. It arises from the nasal portion of the frontal bone, the frontal process of the maxilla, over here, the lacrimal bone, and the medial palpebral ligament. The orbicularis oculi inserts into the skin of the eyelids. It surrounds the bony orbit and inserts into the superior and the inferior tarsi, medial to the lacrimal puncta. The orbicularis oculi functions as a sphincter that closes the eyelids. Its palpebral portion closes the lids gently, as in blinking, and the orbital portion over here, the orbital portion, closes the eyelids more forcibly. Again, a favorite question, the palpebral portion medially of the orbicularis oculi closes the lids gently when we blink. The outward orbital portion of the orbicularis oculi closes the eyelids more forcefully. The orbicularis oculi is innervated by terminal branches of the facial nerve, primarily the zygomatic branch. The orbicularis oculi has three parts: an orbital part over here, following the cursor, which is thicker and surrounds the orbital margin. We have a palpebral portion, more medially, which is thin and lies in the eyelids. And we also have an even smaller lacrimal portion. As a muscle of facial expression, this cutaneous muscle lies within the layers also of the superficial fascia. All of the muscles of facial expression are derived embryologically from the second pharyngeal, also known as the branchial arch, and are innervated by terminal branches of the facial nerve, also known as cranial nerve 7. So again, all muscles of facial expression are from the second pharyngeal or branchial arch. Moving more inferiorly is the orbicularis oris. The orbicularis oris arises from fibers near the medial plane of the maxilla, above and from the mandible below. Insertion: the orbicularis oris inserts into the skin of the lips and into the mucous membrane beneath the lip. The orbicularis oris acts primarily to close the lips. Its deep and oblique fibers pull the lip toward the teeth and alveolar arches. When all of its fibers act together, they can protrude the lips. The orbicularis oris is innervated by terminal branches of the facial nerve, primarily the mandibular branch. The mandibular branch of the facial nerve, also known as 5-3, well, of course, others would call it V3, the mandibular branch of the facial nerve. A major portion of the orbicularis oris is derived from the buccinator. This would be the buccinator over here, in this segment, and blends with other facial muscles around the oral cavity. This muscle is especially important in speech because it alters the shape of the mouth. As a muscle of facial expression, this cutaneous muscle lies within the layers of the superficial fascia. Speaking of the buccinator muscle is more medial. It is more medial to the orbicularis oris. The buccinator arises from the mandible, the pterygomandibular raphe, and the alveolar process of the maxilla and the mandible. The buccinator attaches to the angle of the mouth. The action of the buccinator is that it contracts the muscle, pressing the cheek against the molar teeth, and it aids in chewing. The buccinator muscle can also expel air from the mouth, as when a musician plays a woodwind or a brass instrument. The buccinator muscle is innervated by terminal branches of the facial nerve, specifically the buccal branch. By pressing the cheek against the teeth, the buccinator holds food between the molars. When the muscle contracts too forcefully during chewing, the teeth bite the cheek. The term buccinator is Latin for a trumpet player. This muscle may be well developed in a trumpet player. The buccinator is a muscle of facial expression. Fibers of this muscle blend with other muscles around the mouth. Therefore, the buccinator, being a muscle of facial expression, still is derived embryologically from the second pharyngeal or branchial arch. Let's go down more inferiorly into the platysma, this huge strip of muscle over here, the platysma. Origin: the platysma arises from the superficial fascia. covering the superior portions of the pectoralis major and the deltoid muscles, as pointed in the cursor. The platysma ascends over the clavicle and is directed medially to insert into the mandible below the oblique line. Other portions of the muscle insert into the skin and subcutaneous tissue of the lower portions of the face. The platysma draws the lower lip and the corner of the mouth inferolaterally and partially opens the mouth, as during an expression of surprise. When all the fibers act together, the skin over the clavicle and the lower neck is wrinkled and drawn upward toward the mandible. The platysma is innervated by terminal branches still of the facial nerve, specifically the cervical branch. And again, as a muscle of facial expression, it is embryologically derived from the second pharyngeal or branchial arch. We will continue with the different muscles of facial expression in our fourth part to follow. Thank you very much for joining us today.